All right, well, thank you all so much for being here. My name is Emma Cortez, and we're going to be talking about emergency medicine in Indigenous communities this morning. And I'm joined by Dr. Ken Bernard, Dr. Vijay Kannan, and Dr. Sachita Shah. So I'd like to just start by thanking all of you for being here, and also a big thank you to our panelists for joining us from places all over the country. We're really grateful for you to come here and talk about your experiences. Just very briefly, I just wanted to give a brief introduction for everybody. So Dr. Bernard is the chairman of emergency medicine at the Prince William Medical Center and the medical director for the UVA Community Health, and also a member of the Turtle Mountain Band of Chippewa. Dr. Vijay Kannan is the director of the Office of Clinical Performance and Health Impact with Indian Health Services and Headquarters, and an emergency medicine physician. And Dr. Sachita Shah is an emergency medicine physician at Alaska Native Medical Center with the University of Washington as a professor in the Department of Emergency Medicine, an adjunct associate professor in the Department of Global Health, and director of the Global Emergency Medicine Fellowship Program. And I am currently a Global Emergency Medicine Fellow at Brown University and work also in Pine Ridge Hospital on Pine Ridge Reservation, and formerly at Sells Indian Hospital in Arizona. So we have no disclosures. So we're going to touch very briefly on the historical context and the present state of Indigenous healthcare. And then we will talk about various aspects of health, of careers in IHS-related positions. We'll talk about cultural humility, building longevity in a field like this, and then how we can build solutions and move forward. So with such a short amount of time, I'm not going to be able to really explain the complexities of the history of Native Americans and Indigenous communities in the United States. But I feel this logic model does a good job of describing how the very complicated and adverse historical events that happened to Indigenous communities in the United States had an effect on their healthcare today. So all of the issues that I'm going to be talking about and the challenges that this community faces did not happen in a vacuum. You know, they're related to very, very specific things that happened, and you know, very traumatic and violent things that have a treatment that has been towards the Indigenous communities, and sometimes perpetrated by our own government. So, you know, these things have a long-lasting effect, and so everything that we're going to be talking about today is related to something from the history of these people. So, and again, like I said, I'm not going to be able to go into it too much, but I just want to make it clear that it's related to something much more complicated and vast. So, briefly here, if you look at the health disparities here, the life expectancy is lowest among American Indians and Alaska Natives. As you can see here, it's significantly lower, sometimes by about 15 to 20 years lower than the national average. In Pine Ridge specifically, where I work in South Dakota, the health disparities are quite staggering and representative of the issues that people are facing around the country. So, for example, in 2020 to 2021, the suicide rates increased for Native American males and was the highest rate at 42.6 per 100,000. And also the highest in females was among Native American females as well. And 20.6% of individuals live below the poverty line compared to the US rate of 12.5. So it's a big difference there. And I won't go through all of the details of these slides, but I just wanted to show the different rates, incidence and mortality of different conditions. And this is specifically looking at Pine Ridge from the Department of Public Health in South Dakota. So as you can see, the histogram bar in yellow is the Native American populations. And I feel like these graphs speak for themselves in that the rates for these different cancers are much higher. And then the top graph is the rate of colonoscopies, colon cancer screening. It's much lower in Native American populations. The yellow trend line represents those for Native Americans. You can see it's going up for infant mortality. And pregnancy-associated deaths is also represented by the yellow bar. You can see how much significantly higher it is. I couldn't include all of the slides that I wanted to demonstrate the true reality of the impact of these conditions, but just wanting to kind of set the stage for the current situation and the reality that many people live in right now. So the area in yellow overlies perfectly the same exact area as the Native American reservations in South Dakota, and you can see out of the whole state they have the lowest life expectancy. So again, just some additional statistics. Like I said, I won't be able to read through all of them. What can we do about this? What is happening to address this issue right now? So wanted to talk about the Indian Health Services. So this is part of the Department of Health and Human Services. And the goal of IHS is to provide health care to American Indians and Alaska Natives. And this is a government-to-government relationship between the U.S. government and Indian tribes. And so this is just kind of an image about where it lies in the Department of Health and Human Services. And I wanted to start by asking Dr. Kannan if you could just tell a little bit about the difference between IHS-run hospitals and 638 hospitals.
Does this work? Yeah, there we go. So the IHS is part of a larger system that we abbreviate as the ITU system, okay? And this system is what collectively cares for Native Americans across the country. It's got 3 arms. The Indian Health Service is the I, that's one arm, and that's federally run facilities, of which there are about 675. We've got 44 total hospitals. We're the 15th largest health system in the US. So what I usually do when I have meetings with external partners here in the DC area is I have a list that I keep in my room, and I in my office, and I put it on there, and I can find the health system local to their state and say, well, this is the largest system in your state. We're bigger than that one. It's a very large system. So that's the IHS part. The T part in ITU is the tribally run hospitals, which also are collectively part of that. They receive federal funding, but they are run and owned by the tribes. And then the U part is urban Indian programs. There are 41 of those right now, I believe, across the country. And they provide services on reproductive health, substance use, mental health, that kind of thing to Native Americans that live in urban areas. And so collectively together, that is the ITU system.
Thank you. Yeah. So within IHS, there's many different kinds of careers. So there are different options that people can pursue. So there are clinical careers listed here, and then there are also, so here's clinical paths, administrative roles, and academic medicine. And so this is the clinical roles that I was discussing. And then within administrative roles, I just wanted to give an example of all the different kinds of administrative roles that people can do within emergency medicine and related to IHS. There are academic roles that people can take on within IHS and be related to working with Native American populations. And so my first question to all of you, and Dr. Bernard, if you would like to start, is do you want to talk about the arc of your career that led to your current position right now, and if there was any major pivot changes in your career that was a turning point for you?
Sure. Okay, if I talk without a microphone, I hate to sound one voice, so having it on is terrible. First, I think it's great to talk about history and context, and as a matter of fact, I think taking a brief moment just for a land acknowledgement is probably appropriate, just talking about the subject. Right now here, we're standing on the land of the Lenape, or the Delaware, and these are my direct ancestors from the San Algonquin language group. So thankful to be here and reflect on both that history, but also being able to talk about this topic in their ancestral homeland. And then another thing, I was looking quick Google. Every time I do this, and I think this is part of cultural awareness and humility, every place that I go that I think is a big city, kind of look at the indigenous populations that were there and maybe tie something close to history to learn a little bit about it. So if anybody hear about the walking purchase of 1737, so that was William Penn, and likely his sons, had brought up an old deed, potentially forged, that said they were allowed to claim any land that one could walk, a man could walk in a day and a half. So what they ended up doing is presenting that to the state legislator. They cleared a large tract of land in half, and then they found the fastest runners that they possibly could. And they let them go for a day and a half, and they basically seized 1.25 million acres of Lenape land. So that's kind of interesting. So history is important. You can understand the trauma, loss of culture, especially since most indigenous tribes have a very close tie to the land. I feel like my arc has been long. My first memories are about being 3 years old. I was in an Indians into Medicine lecture hall, likely with my mom, who had me. She's a general practitioner who's been a clinic director for the past 25 years, and had me in high school and then made it into medical school. But I feel like that was the early start. I don't think there was anything else for me to do but medicine. I'm terrible at math, and the little I know about history, that's pretty much what I just said. So you guys know. So early on, did the health profession scholarship, knew I was going to come back into the Indian Health Service, was interested also in, let's say, administration, but more leadership, I think, of departments, and was lucky enough, and you certainly have enough opportunities for folks that want that exposure early in their careers, either to be deputy directors, medical directors, EMS directors, quality directors, what have you, to be able to do that in the Indian Health Service, because there's often a void in a vacuum. And most leaders who the IHS, or probably in most rural communities, are there by accident. But I was hoping to make it a bit more deliberate, and got lucky enough to have one of those positions. And then became a government contractor, started a small emergency services company, thinking like maybe we could have a bit more impact on recruiting, and noticed that there were some, I'll say, market and ethic failures with the temporary staffing services that we were seeing, and I was utilizing as a director with the IHS. And then after COVID, moved to Northern Virginia. Like, what the hell, this guy's in Northern Virginia, why is he here? I forgot to put on there that I'm a clinical fellow or a consultant with the Centers of Indigenous Health out of Baltimore and Hopkins, the Research School of Public Health, and now doing research and consulting on clinical projects for them. So that is to say, the path was long. I did one of the scholarships, which was fantastic in the payback. Got great exposure to leadership, then able to transition that into a government contractor, starting a business and being an entrepreneur, and now finally coming back to research and clinical consulting a million miles for where there are even tribes. So you can get involved with the IHS, even at a distance, including in DC, although that's a murky place to be involved, but can be done and can be navigated, and there are folks that do it well.
Thank you. Dr. Shaw, would you like to respond?
Yes, I come from a less murky place out in Seattle. And so similarly, I feel like the arc has been kind of winding and probably will continue to wind. I came into medicine using a global health lens. Both my parents are doctors, both from India. I kind of grew up going with my parents back to India to do mostly just hanging out while they did medical care, but when I was a medical student, I was allowed to kind of have some experiences with patients, and entered residency pretty like straightforwardly going into global health after I was done. But while in residency, got roped into an ultrasound project and took this like turn doing an ultrasound fellowship that led into my niche right now, which is ultrasound and global health. And also running a global health fellowship program. When I was in Malawi in 2011, I was speaking with a very dear friend who grew up and worked on the Pine Ridge Reservation. And as we were sitting back, both doing medical work in rural Malawi, he was reflecting on, wouldn't it be amazing if there was some way to link a global health program with a rural Indigenous health experience for fellows that want to go into rural healthcare, but you don't necessarily want to only do it globally. It's like the same spirit of person that wants to do work with Indigenous populations in the U.S. as wants to do work with populations outside the U.S., especially rural care. That was in 2011. Fast forward to 2013, this individual joined me at University of Washington and said, I'm here, let's make that program we talked about. So we spent about 2 years heading out to Pine Ridge Reservation to meet with the chief medical officer, and among others, lots of stakeholder engagement, meeting with the Alaska Native Tribal Health Consortium, the CEO. Alaska Native Tribal Health Consortium is a group of 229 tribes. It's part of the T part of the ITU, so it's tribally run. They receive federal funds, but instead of letting the federal government oversee their healthcare, they formed tribal health organizations, and then formed a giant umbrella organization, the ANTHC, that administers the healthcare through these different THOs throughout Alaska. So we met with leads from several different THOs in Alaska as well, and it took about 2 years of kind of pitching this idea, but everybody was really receptive. Could we run a fellowship in partnership with the University of Washington, where the fellows would work and live in rural Alaska as part of the ANTHC, and then in their second year of fellowship be able to be partnered with a local health organization. So that's what I've been doing for the past almost 8 years now, is running this program. I work part-time at the Alaska Native Medical Center. I find that super rewarding, and what's even more rewarding is probably the work with residents and fellows who end up going into practice and doing these programs. That's my story.
Thank you. Dr. Kanan.
I also came from a similar global health background and lens. I finished a global health fellowship and then stayed on as academic faculty. So I was in the academic space for a few years and then left and went to go full-time. So during the academic phase, I was spending a third to a quarter of the year doing global health work, predominantly in sub-Saharan Africa, a little bit in Southeast Asia, and then decided to take a full-time post with WHO over at headquarters in Geneva. So moved out there and just continued to do global health work with them. You have to make a decision at that point, because when you work out there, you're not allowed to work anywhere else, which means you can't work clinically. And so as an ED doc, a few years out of training, you don't have the longest shelf life of not being active clinically before you have to make a call. Am I going to work clinically ever again or not? And you know, I went to WHO in January of 2020, right before COVID. That also shifts your lens on in terms of the importance of being near family, right? And I think that most of us, when we go through training, we pick whatever the best residency is, and we go there, and whatever the best med school is, and whatever the best fellowship is. And we don't think about being near our family. And then as you get older, especially as you have kids, you're like, maybe I should be closer to mom. And Europe all of a sudden seemed really far away, and you couldn't even walk to the grocery store. You certainly couldn't go home to America. So I started looking around, and interestingly, the person who I sat next to in the office used to work for IHS. My wife, who also worked for WHO, her boss used to work for IHS. Our quality director at WHO used to work for IHS. And there's just this group of people, it seems, that rotate between organizations. They rotate between WHO, CDC, USAID, MSF, ICRC, IHS is part of that rotation. And so I went and I first worked in the T part of the ITU system. I went up to Fort Defiance and checked it out there, and really fell in love with it and realized, you know, this doesn't actually feel that different. I started off in international emergency medicine, I would say, but I have not left global health. I work with 575 sovereign nations, with independent health systems, with people who are culturally different than I am, who often speak different languages than me. It does not feel that different. A lot of the tools that we are implementing now in IHS are things that I don't directly from WHO. And when I was working there, I've just taken spreadsheets and cleared them out and then put them in with new data. It's the same process, the same concepts. And so it felt like a logical continuation, even though it may seem not to appear that way at face value. So that's kind of how I ended up in that setting.
And before we move on, is there any questions from the audience about that specifically? Okay.
Can I ask a question? How does the system in the U.S. differ from that of Canada? Maybe that's a bigger question.
Yeah, I can take that as clear. Okay, but you're also pretty close. You can see Canada from here. So the Canadian system is different in that because they have a universal and government-funded health system, they don't differentiate in who they give care to between it being someone who's of First Nations versus someone who comes from a colonial background, and so there isn't a dedicated bespoke system for providing healthcare to First Nations people like we have here in the US, which has pros and cons, but that's the primary difference, is that you won't find a clinic dedicated to that. You will find remote clinics, and those remote clinics may be in areas where it's almost exclusively people from First Nations descent that are living there, so they're providing care that way, but it's not intended to just be that. I think that's probably the principal difference between that and here, where we have a system that, because of treaty obligation and duty, is dedicated to only providing care for Native Americans. I don't know if you have anything to add to that.
I feel like the one thing I'll say about Alaska that makes it a little different is a lot of, outside of Anchorage and Juneau and Fairbanks, a lot of the communities, especially coastal communities, is like 90% Native, right? So it's the vast majority of the population presenting to any of these little tiny critical access hospitals, or certainly the village health aid, like, and they call it a clinic, but it's like a room with a tackle box with a couple rooms in it. It's very, very like rudimentary. They're all in the Native system, and so when a non-beneficiary or somebody that's not affiliated with the Native health system, that's not, Native American or Native Alaskan, presents there, they can still get care. It's all free, but when they need to be admitted to a hospital, we don't admit patients to Alaska Native Medical Center unless it's like a dire circumstance and there's no other beds. We try our hardest to transfer out, and we also can't write prescriptions that they can fill at ANMC because the meds are all free. So there's a couple little like caveats for taking care of non-beneficiaries in Alaska, but the system is set up because there's so many Native Alaskans, especially rurally, to just be the system that people use for the most part.
And just to add one more thing to it, having spoken with some Canadian emergency physicians, the way that they have described it is if what you're interested in specifically is working with First Nations population, that differentiation is made at the point of research. So people who work in an academic setting will often at that point say, I am not differentiated. I'm going to only work with First Nations issues. But people who are working clinically at the bedside, they don't find a spot, short of as a function of geography, where they have chosen to only work with that population.
Any other questions right now? Okay. So briefly, I just wanted to discuss cultural humility. So for those of you who are not familiar, so cultural humility is a lifelong commitment to self-evaluation, critique, and redressing power imbalance, and to developing mutually beneficial and non-paternalistic partnerships. So I won't read these, but again, just some of the core principles for people to kind of keep in mind as they're, having the privilege of working within other cultures. So there's different approaches that many people have taken and many people have talked about, and really the idea again is that this is a lifelong understanding that you cannot possibly know everything about a culture that you are not familiar with, and that you are there, to learn, and then you have to be able to respond to those changes. And doing a one module online doesn't mean that you're culturally competent, and there's no way to be competent in a whole culture that you don't know. So that's really the main idea. And so based on that, I wanted to ask, what was and is your approach to cultural humility and cultural responsiveness as you learn more in clinical practice? And what recommendations do you have for other providers? Dr. Shah, if you'd like to start, I'll just go down.
Sure. I think coming from a background of global health or international medicine was really helpful, just in that I was used to being a doctor or a clinician in many different places where I might not necessarily have spoken the language. And I think having that background helped me to just recognize very quickly, I'm in a global health space, even though I'm in Alaska or I'm on the reservation at Pine Ridge. We have an orientation for our fellows that includes, it's one module, right? It's not, it's nothing. But just it lays out kind of high context and low context cultures with regards to like cadence of speech, eye contact. Is it like a lot of times in Western medicine we'll say, oh, they need poor eye contact, they're avoiding something, but like direct eye contact is considered rude in many Native Alaskan cultures, right? Not allowing time for people to speak is a common mistake that people make. How quickly we speak, how many pauses there are, not sitting down, like all these things that we do in emergency medicine just because we're trying to be efficient can actually be perceived as pretty rude. And so it's a good kind of set the stage, but I often, it's like every shift or every time I'm working in a situation, I have to kind of reset myself because we're trained a certain way in emergency medicine that I think is in direct conflict with how best to communicate with many patient populations outside of, the lower 48 and in non-IHS settings. So, but yeah, so I think it's a continual learning experience. I think it's probably going to be a lifelong learning experience. Times change, but yeah, just being open, I think, is my best advice, and slowing down.
Thank you. Dr. Bernard?
I like that about the learning experience of growth mindset. On the way up here from DC, I was listening to a book. I listen to all my books now. I don't even read. But Adam Grant and Hidden Potential. And he was talking about the differences between polyglots and people that are just speaking their own language. These polyglots didn't have any extra talent. They weren't smarter. They didn't have the cognitive power to be able to pick up languages a little bit quicker. What they did is they were really comfortable with looking like an ass for the first time and going out there and then being honest about their mistakes, reflecting on it. So they got comfortable with being uncomfortable in uncomfortable circumstances. I think not only germane to emergency medicine, but probably medicine in all, you get paid for being perfect. You get paid for being outcomes-based, results-driven. You don't get paid for being progressive. You don't get paid for making a mistake or trying something that's really difficult or challenging yourself beyond what you thought was possible. So I think probably the same thing with languages probably pertains to picking up and then, and endearing yourself to another culture. It's probably just got to be uncomfortable and just jump in. And I think I've experienced that, at least, working in the Southwest quite a bit. Well, most of my family is still in North Dakota and the Turtle Mountains. And I wouldn't go there. The reason I wouldn't go back home is because I would find it incredibly difficult to treat every single one of my family members. And that's how close we are, right? I think that transference would be a little bit difficult for me, so that's why I was in the Southwest. But for everybody that came and traveled there, just jump in the community. Like, you show up to the community talks, you see if you can go to a healing circle and ask respectfully if that's something that you can take part in. Go into the rodeos even, which is a big cultural event in Navajo country. Just jump in.
Thank you. Dr. Kanan?
The only thing that I really want to add to all that is when people are thinking about working in these settings, recognize that there are now 575 different Federationist tribes. And I've heard described that when colonists arrived, that many of those tribes are as different from each other as they were from the European colonists, right? And so there is not a cultural humility teaching or cultural competency teaching that you can give to work with Native Americans and influencers. It doesn't work that way. They're very, very different cultures. And so when you recognize that, you learn that you just need to listen and be very, very deliberate about learning the people that you are working with. And yeah, it can be very complicated depending on the site. I see several people here who work in the Desert Southwest, and if you work with people of one tribe, you may find that death is something that you are not supposed to talk about, you're not supposed to bring it up, or you're inviting it into the room. And then you have other people who really would like to hear that, and they would like to have an open and honest conversation, and it depends what tribe they're in. And you can kind of tell from their name a little bit, maybe what tribe they're in, but that takes time. And so I think going through and recognizing that if you worked one Native American tribe, one site, work with one site, one tribe, they're vastly different. Each time you're going to have to go through and relearn. Just as you would if you went to Europe. You can't go to France and say, I know exactly what to do when I go to Germany. So that's the only other piece I would add to that.
Any other questions from the audience about that? Or any unique experiences anyone else has had related to that? Okay, we'll move on. Building longevity. So IHS and working with Native populations, there's a high turnover rate. And so with this high turnover rate, I was hoping that we could speak a little bit about why that is and what factors keep you motivated in your work and how you try to build longevity into your career. Dr. Kanan, if you'd like to start.
Sure. I'll answer it in two ways. So I think just acknowledging the problem, right? So there's a 40% position vacancy rate in Indian Health Service right now, 40%. 30% overall vacancy rate across all types of staff. It is an issue. I think it is my belief that the principal driver in that vacancy rate is rurality, it's geography, right? I have an 8-year-old. He's 8 and a half. It's very important to talk about that. I need to have him in a good school. I need to have cultural opportunities for him to go through and go to museums and go to events. I need to have him in a setting where he can, live and play in a way that will raise him how I want to raise him. It is very difficult to find those kinds of opportunities. It is difficult to find a grocery store. It is much more difficult to find a lot of these other opportunities in some of these settings. And you don't see a lot of people raising their kids for the duration of their childhood out in those settings. It is the unfortunate reality of the situation. And we are emergency physicians. We have options, right? We get options presented to us weekly in our emails of staffing agencies that are presenting something, or me calling you when you don't want to be called and saying, here is an urban opportunity. There is a museum here. There is a good school for your child here. And it may even be paying more than IHS. And so it's no wonder that you have a 40% vacancy rate. It's just a very difficult thing to do. How do you build longevity with that? I think recognizing that the career is incredibly rewarding. The career does not have to be spent exclusively in one site, that you can move around, that you can shift. And that some of these sites, depending on how flexible they are and you are, you can be within striking distance of a large city, you can live in a large city, and then you can go out there. And so I think you have to think a lot outside the box. You will not be bike commuting to work and also living in an area where you have these opportunities. But you certainly could stack your shifts, right? And this is something that IHS has gotten a lot more progressive on very rapidly over the last few years, because we were stuck in an antiquated time for a long time where we did not offer that opportunity. You had to work. You had to clock in and clock out. You had a number of hours you had to work every few weeks, every 2 weeks, right? You don't have to do that anymore. Now there are plenty of sites that are allowing you to stack shifts and be more like normal community emergency hospitals. And I think that's going to do wonders for longevity. Another thing is, the location or sort of the culture in the specific site that you work in can make it extremely conducive to that. We have sites where you are one of the new people. You have only been there for 5 years, right? We have other sites where you are the senior-most person in the entire hospital and you've been there for 5 years. And a lot of that is just due to the leadership. And so, in the abstract, that's my answer to that question, is the reality causes a problem. Your flexibility and the site's flexibility provide answers to that problem. Personally, for me, I have a somewhat odd job in IHS. So I work over at headquarters. I'm in the DC area in Rockville. I go out to the field quite frequently. We have 22, about to be 21 federally run IHS emergency departments. I have worked at either clinically or in an administrative role at a third of them, and will continue to expand that. So I go out to the field pretty frequently to do that. And in the meantime, I have what I think, and we'll talk about later, as a really rewarding career doing administrative work and health system strategy and health policy. And so that's the way that I've approached it, is to find a balance between the clinical and non-clinical, between the field and non-field, and to put myself in a place where I think that I could raise family for a long time. And that could be done broadly across IHS. You don't have to live in DC and commute out. You can live in Albuquerque. You can live in Phoenix. You can live in a lot of different places. To try and have that.
Yeah, I think you covered the main one, but isn't that the problem with every rural emergency department access department? We are consolidating, condensing all of our resources into large metropolitan and urban areas. So there are a lot of places in rural America, not just IHS, that are suffering. And you hit the big ones, right? It's location, it's time, and money. And directors, as well as area directors, as well as IHS in general, and tribal communities have to figure out how can we be flexible and more creative about the packages that we're offering to be able to entice and bring people here. Then when you get them there, so when we were recruiting to the Indian Health Service, and we got a lot of residents and people who were first out, and I was like, great, we're going to turn you into an excellent community doctor. Give me 3 years, and you can go to any place you want after that. You want to go to a trauma center, try to get you into an academic center again, you might be able to get some research on the side. You You also probably have a title with an EMS director or creating some other program here for the hospital. Let's do that. And then, so when we did that, or some people like, hey, you belong here. I think this is going to be a place where you're really going to start off and grow. Belonging was a big part of the purpose and passion and having people feel comfortable and being elsewhere. So really building a team over those first few years. And then the second thing that we communicated is that we matter. We make a substantive impact here. I mean, we all have been we all trained at academic medical centers, and you could throw a rock, and there are probably 20 people that can do what you are doing, and maybe even do it better. Okay? But when you're out there in the IHS, and like you might be out of residency 2, 3 years, maybe 5 years, and you're the proceduralist for the hospital, and you're the critical care doc, and you're the one who has a specialist in event management, you are the person that they are going to look to. I know that's a lot of responsibility, a lot of pressure for folks, but I think to say that what you do truly matters in that circumstance spoke a lot to people. So belonging and mattering, we try to keep people there. And then the ante up is you got to figure out the time and money, and then work around and be creative with location.
I think, yeah, and I agree with all of that, and I think the only thing I'd add is just that I think full-time IHS work is not for everybody, but that there are many, many ways, especially if you're academically affiliated, which I imagine many people are, as being SAEM, where you can build these long-standing partnerships with an IHS site that might be like, local-ish. So the fellowship example from University of Washington is one, but we have recruitment programs in the WAMI region and Montana and Alaska and Idaho, where we draw pre-medical students and medical students into our university system with the hopes that they'll return home and practice medicine in their communities after. We have resident rotations for folks that maybe have never tried working in an IHS site but want to get a little bit of an experience to see if it's something they might do. We have the fellowship program. We have a near 100% retention rate for everyone in our fellowship program.
Wow.
Since they've left, they've gone back and worked in an IHS setting, and a couple escaped to like rural Vermont and rural Maine, but still rural. Similarly with our resident rotation, I see Emily in the left there. One of our former graduates from the University of Washington, many of our residents have left our program, had these shorter elective experiences, but then gone and worked full time and stood up really extensive programs in Mount Foundation, for example. So far away from University of Washington, but they get that kind of little nugget. Our ultrasound fellow works with Southeast Regional Alaska to do ultrasound training for their clinicians to kind of, even though they're working rurally, to give them that academic connection of learning a new skill mid-career. Oh, let's do focus now. And we can have the university help out with quality assurance, and it's a more satisfying way to practice. Our fellows are EM trained, but they're also working alongside family docs. So the family docs are teaching them how to put in an X1 on, and then they're teaching them how to put in a chest tube. So there's this like learning exchange that
Not at the same
happens.
time.
Not at the same page. Yeah, so I think keeping learning and teaching happening, and even being in academia, just those small reaches of like, hey, what can we do that's cost neutral and fun for everybody is, I think, a really great way to keep everybody practicing, not burning out, even in academics.
Yeah. And Dr. Shaw, I know you touched on this a little bit earlier, but what would you say has been one of the most rewarding parts of your career working with these communities?
I think I'll do the personal and professional situation. I think personally, I really have enjoyed the storytelling aspect of taking care of elastic patients. I feel like especially the older adult patients, like taking care of grandma with chest pain is just deeply satisfying when they're coming from a village and they took a long time to get there. And so I think from a patient population standpoint, just as a physician, I find that to be my favorite patient population. But professionally, I think like seeing my residents and fellows kind of get some training and then go out and do amazing things that I could never have done as a leader way.
Dr. Bernard?
Yeah, personally, professionally, I like that right now. So personally, it's been the friends that I've met along the way, and colleagues that I've made there, many of them that are still there, mostly in the Southwest. So yeah, for sure. And what they're now, just doing amazing things. And I called them on to be like, hey, I wish I was back there with you. And know now, practicing in another sort of suburban environment, that was the best group of physicians I was ever around. I mean, the inpatient, the critical care, the OB, the needs, no doubt, hands down. And when I talk, I'm hanging out with people who can't do paracentesis and stuff anymore in the emergency department. I'm like, oh my goodness. But that personally, those relationships have been very meaningful. Professionally, there's been a few. So we were talking as directors back in 2018. We were talking about things that were challenging to us. The pain points 1, 2, and 3 were staffing. We got together, like 7 of us with some nurse managers. There's even some administrators that were there in Port Defiance, and Sean had, and Drea had hosted it. And out of that came the Native American and Rural Emergency Medicine Consortium, a terrible acronym. They've now changed it to MRIC, and it's now its 5th year of being an academic conference, an educational conference for folks that are practicing in Indian health service. And I love that we were able to bring that forward and create that legacy. And then most recently today, with work some folks from Hopkins and Mayo, we just secured a grant to start talking about and maybe developing the first Indigenous school of medicine. So a true grow your own program where you take from, I'm talking about from pre-K to elementary school to STEM projects in high school, eventually getting to tribal colleges, and then getting folks admitted into Indian School of Medicine and potentially an IHS residency to complete the circle. There's a gap there. So we're starting that, and maybe are a generation away of having the first Indigenous School of Medicine. So maybe the most rewarding thing hasn't happened yet. I hope I can talk a little bit more about folks if they're interested in getting involved.
I think we're probably just going to do this thing where we continue to say everything they said. It's the patient, it's the colleague, that kind of thing. So my addition to that, I guess, would be the impact. So you were talking a little bit about this earlier. The nerdiest friend that I have lives in Boston, and she once told me once, if one more doctor moves here, they're going to start precipitating out a solution. That is a joke that not many people. And so you go out to a lot of these sites, you see that if you don't show up for your shift on Friday, no one will show up for your shift on Friday, right? And so at an individual level, the potential for impact is enormous, right? And that continues, that carries through as you move forward through administrative roles and as you move through into national health policy roles, the things that you can do. And this is something that I like about working in government. Despite everything else in terms of chaos right now, I still very firmly believe in the ability for government to affect change. I think that the impact that you can have in working in this setting is enormous. We go through the office that I run is meant to provide monitoring evaluation for clinical care. So it's how are docs doing at that site and figuring that out. And one of the things that we're monitoring that is we talked a little bit about the life expectancy difference here. Okay, when you look at how USAID was looking at life expectancy and what they were doing in terms of their impact of moving the needle, is they said, what's the percentage of deaths that are occurring below 50? Okay, that was a USAID metric. An IHS metric that we have is similar to that. It's our life expectancy delta. So what are the number of deaths, percentage of deaths that are occurring within that delta between the life expectancy for the general American population and specifically for the AIA population? And I firmly believe that that is a delta that we can close the gap on. And when you see that, when you go through and you look and you say, hey, this new policy that we put in place, this group that we're forming in emergency care here, and what we're doing in terms of sharing best practices and policies and guidelines and changes that we're making in terms of the way we collect data and feed that back into quality improvement mechanisms, we will close that gap. And I think that's a needle that moves on a totally different scale than the needles that I saw when I was working in other settings. When I was working in academics, when I was working in really high-income hospitals, you know, if you're moving the needle there, you're moving the needle on a fraction of a percent in terms of mortality, and you see enormous benefit from that, right? We get high single, low double-digit changes in mortality from some of the things that we do here, and that extends to global health too. So I think that it's the potential for impact that really is the big thing, and it's by far the most rewarding part of it.
I'm glad you brought up EMRIC, because that's one of the best conferences I've ever been to. I mean, we love SAEM, don't get me wrong, but EMRIC, yeah, close number 2. But EMRIC really was an extremely amazing experience, and I really look forward to going there every year. It's really unlike any other conference I've ever been to. So if anyone has the opportunity, you should definitely go. And this also is similar to something Dr. Bernard was mentioning. So there is an underrepresentation of Native Americans as physicians in the U.S. And, you know, we kind of talked, this also did not happen in a vacuum. This is also related to the social disparities that exist. And so there are different mechanisms that people are doing to try to change that, like you were saying, having schools more focused on this patient population. So I wanted to ask, what recommendations do you have for trainees who are interested in working with Indigenous communities? And Dr. Shah, if you'd like to start.
Sure. I would definitely recommend trainees medical students or trainees residents.
Either medical students or residents.
I would recommend them to see if their institution has any faculty members who specialize in this area, who have experience in this area. If there is an opportunity for an elective, even a global health elective could be used as working in an IHS site. If their institution has any formed partnerships or practice license agreements already, that's way easier than standing it up. And if they don't, then kind of going outside their institution to seek mentorship at another institution with close ties or programming around that to see if they could do an away elective or have an advice. But getting a little tiny bit of that experience in training can really help shape and inform what kind of job they want to take after, or how comfortable they feel kind of jumping into that pool after a full-time job.
Absolutely. Dr. Bernard?
I'm wondering if IHS still have that tab for like students and scholarships. Like on the main website, I'm thinking like where I would look for that information. Yeah. And you know, in some of these, it might be great if you already have that connection with a faculty member or somebody who has experience. But then also I would encourage trainees, like it literally might be a phone call to that CMO or that medical director of that facility, and you get an email, which is going to be on IHS.gov, and then you're going to have to come up maybe with your institution's memorandum of agreement and push it forward. You might have to create it yourself and make that a project potentially. Or there should probably be a repository where there's that. Yeah, and there's a database now where where that information is easily accessible. So that's where I go.
So things have changed dramatically here just in the last 4 months with IHS in terms of how you do this. Looking around the crowd, I think that there are probably more people who are helping coordinate this with trainees than trainees. But so I'm going to speak to that perspective. But it applies to both. So I'm going to organize my thoughts on this in terms of level of effort. And so the lowest level of effort opportunity for someone to have is an elective rotation. And elective rotations used to be that what you had to have is a historical bilateral relationship. Somebody at your hospital worked at an IHS site or a tribal site 30 years ago when they trained, and they kept in touch with them because they really loved it. So you talk to them, and they're the person. Everyone will direct you to the one person. When that person retires, you're done. There's no more rotations, right? But you have to know this person. That is absurd. We want to continue to preserve those relationships because they're important, but that shouldn't be the principal way by which people come across elective rotations. So what we've done is, if you previously went into our website and somehow managed to actually find the medical student elective rotation site, it was only for the Navajo area IHS. There are 12 IHS areas. They're terribly named. Okay, some of them are named after the city in which the regional headquarters is. So there's Phoenix area IHS. When I hear Phoenix area, I think Tempe and Scottsdale and Phoenix. I don't think Arizona, Utah, Nevada, and part of California, but that's what it actually is. And so it only included one small area. We have now revamped that site. So all 12 IHS areas are included, and we're actively doing that data import. So we've got 4 areas so far in the 12 that have said, here are the rotations we can support. It was also only for medical student rotations, and now it's also for resident rotations, and it's an interactive map. So you can go through, you can click on it and say, I'm a resident, I am interested in emergency medicine, search, and it will give you all the sites that do resident rotations in emergency medicine. You can say I'm a med student interested in family practice, search, and it will give you those. You can narrow it and say, I only want to do things that are located in the Great Plains area IHS, because maybe you're over in South Dakota, and you only want to stay local. You can do that too. And when you hit send an inquiry, based on what you clicked on, it goes to the right person and not the CMO of the hospital, right? So it'll be the person who has said, I am signing up to be the key person, the point of contact for an emergency medicine rotation at the resident level. Because you might actually have different people at the med student and resident level too, right? And so now it's all very streamlined and functional. And so those rotations work. The other problem that you brought up is memorandums of agreement. Those were signed historically between either one site and the university, or between one region or area and the university. No longer. We now have a national level template. When your university signs with IHS, you can rotate anywhere that's a federally run hospital. If you want to rotate in your neck of the woods, or in the Great Plains where your family are, or in the desert Southwest, you can rotate at all of them. You just have to sign one agreement. We will continue to support local area agreements because a lot of times you have medical schools like in Oklahoma. They're not going to send their students, they have decided, further than the Oklahoma region. So they're just going to sign a local agreement. That's completely fine if their students want to be in that area. But you have other places, in Boston, for example, where you don't have anything local. Everywhere is travel, it's a plane flight, it's a trip. So you might want to just sign it at the national level. So we facilitate that. One hierarchical level above that is track programs. So this, I think, is maybe the best bang for the buck. Because when you have people who are dedicated enough as a learner to say, I want to do a global health track, or a rural health track, or an Indigenous health track, and they go through and they sign up for it, it gives you a lot of exposure. And so what we've done is we've created a new MOU where we'll also support the didactic component of those tracks, and we'll support the scholarly project for those tracks. And then we have some continuity sites. So we have sites that are required rotations for third-year residents sometimes. That's another one. And then the last one is residency programs. We have some institutions that are now partnering with us to create residency programs. And in the interest of time, I'll stop talking about that. But if you want to talk about that later, you're welcome to.
Yeah, that's amazing. And one other thing that I will just add, because again, like you were saying, a lot of the people here work with trainees. One thing is also considering how to reach out locally to Native populations within your communities and see how you can offer educational opportunities to those individuals as well. So one thing that we want to do at Brown is try to make sure that we offer shadow opportunities for people, because we all know that applying to medical school, you have to have shadowing opportunities. And, for myself, it was a family member, and a lot of people I know, it was somebody that knew a family member, so it's really hard to get those opportunities if you don't have somebody that already is a physician. So trying to make sure that we are offering those opportunities for people is also extremely important. Just something else that we could be doing, just having shadowing opportunities, something that we don't often think about. So, as we're wrapping up, I just wanted to thank you all again and see if there's any questions from the audience. Any specific questions for our panelists? Yes?
Would the panelists be able to put the contact information up for the slide, or I would be the next?
Yeah, you can feel free to contact me, and I can connect everybody. So, all right, well, thank you so much. Really appreciate you coming here. Thank you so much. Very sincerely, thank you.